Hey there. Hey there, everyone. Welcome in. Welcome in. It's great to see you today. Wow. We've got some cold weather still here in Keene, New Hampshire. And wherever you are, you might be experiencing the same or not. But anyway, we're here. We're going to make the most of it. Actually, I like it because I'm always inside where it's warm and cozy. And I like the brisk, fresh air. It's just meant to be. There's something about it that's really wholesome. So anyway, the days are getting longer though. You've probably noticed that. So as you come into the classroom, I'll just do my normal intro. My name is Rebecca Becky Montrone. I am an holistic healthcare practitioner with a degree in holistic nutrition from Clayton College of Natural Health. I have certified through the Association of Drugless Practitioners, and I'm also an herbalist. So I come from a long line of compounding pharmacists, and also, so I have that DNA, and I also studied herbalism. So we have a full-fledged botanical pharmacy here with hundreds of products, really, when you consider all of our single herb extracts, and then our skincare line and our formulated oral extracts. So you can always check those out. If you're not familiar with Wondrous Roots, go to shopwondrousroots.com. wondrousroots.org, and you can see the vast array of those things we have here. We also have a shop here with nutritional supplements that we don't make, that I use frequently and recommend for my clients, and also available to the general public. Again, our websites are shopwondrousroots.com, wondrousroots.org. You can get from one to the other. Wondrousroots.org is more informational, and the shop wondrousroots.com is, of course, the online store. What else can I say? We're open here physically in our physical location, 103 Roxbury Street, Monday through Friday, 9:30 to 5. And our number here is 603-439-2603. I see clients in private consultation here in the office, or long distance via a Zoom, if that is what we need to do because of your location. So again, you can reach out to me, 603-439-2603, or go to wondrousroots.org, shopwondrousroots.com, contact us and type in there and send it to me, and I will get back to you. Okay, I think that's all I really want to say by way of introduction. So last week I left you with a little bit of a tease about something that happened to my eye, and it happened to happen after I had had COVID. And this was just very recently. So I wondered if there could possibly be a connection. And when I looked and did some research, I found, well, there could be. Now, I can honestly say that there's no actual, what do I want to say, proof that what happened to me was due to having had COVID. But in any case, it's possible. And I think knowing that these ocular, that COVID, the COVID virus itself, having COVID, or even getting the shots, can affect vision and ocular health in several ways. So I thought you might be interested in that too. So I'm going to share my screen. I'm going to, let's see, take you to, oh, again, if you want to participate, and please do, you can type in the chat, you can type in the Q&A, or you can raise your hand and speak, and I'll invite you on to speak. Okay. Share. So you're going to find the information I'm referring to today on my COVID-19 page, which is located, I'll kind of backtrack and show you. Like, so if you go to wondrousroots.org, you will see this page. And then you go to learn, and you'll see a bunch of pages, informational pages that I've been putting together. And one of them is COVID-19. Now, a few weeks ago, back in November, actually, I did a piece on nicotine, transdermal nicotine patches, and long haul COVID, getting rid of long haul COVID. And so you can see that there. And then I have a lot of files on COVID here. So you kind of have to breeze through. If you're interested in my information on COVID, you'll see just a lot of different things there. just this past week, a lot of people, a lot of you and a lot of people in general ask me about shedding and being around people who have had COVID and having symptoms. And we know that that is a phenomenon that's been observed. And of course, the mainstream health education information have tried to really say that that's not possible. And the reasons behind that are because of there's no live vaccine, but the mRNA vaccine is not a live vaccine. It's not a vaccine in the way that we normally think of those. So in any case, I'm not going to talk about this until I read this very long article, which I'll just show you. You can actually go to this. It's very balanced. It's very scientific, but I have not read the whole thing, and it is a full, oh gosh, a 50 something page. I don't know. It's very, very long. It's so anyway, but if you want to look at it yourself before I talk about it, please do. This is done by the Midwestern doctor who I have a suspicion is Joseph Mercola. If not, it's somebody who's very plugged in the same way he does, and he does his stories at a glance. He does them exactly the way Mercola does, but it doesn't matter. It's good information. So anyway, there's that. So anyway, we're going to go beyond that, below that, to talk about what I'm going to be talking about today. So ocular manifestations of COVID-19, yes. And it makes sense, we'll get into in a little bit about that. It makes sense that that would be the case because of the fact that we know that the eyes are vascular, and we know that you can have vascular problems such as stroke and heart attack following blood clots, following either having the virus, the infection, or having the shots. So that makes sense, but it goes beyond that as well. So anyway, I'm just going to read here from this paper. Ophthalmic manifestations may be the presenting feature of COVID-19 infection. In other words, conjunctivitis, right? That has long been associated right from the beginning with COVID-19 as sometimes a first symptom. In fact, one of my clients was down in Florida in 2019, right before COVID-19 was revealed to the world. And he was quite certain at the time that he had it at that point in time. It was probably in November of 2019, as I recall. And really, conjunctivitis, pink eye, was his only symptom. And sometimes that is the case, and sometimes it is the presenting feature of COVID-19. I certainly didn't have it, and nobody I know personally, except for this man, has mentioned that. But it's also thought that the eyes can be a doorway of entry to the virus, and also perhaps even the tears could be a carrier. So anyway, I don't know a lot about that, and I'm not going to that's not really my purpose today. But the eyes, then you look at your whole eyeball, like behind that. And another thing that can happen is like the meibomian glands can get like a folliculitis or something like that associated with, those are the oil glands in the eyelids can be affected. So in any case, I'm going to kind of go through my little history here. I always kind of like, when something like this happens to me, it's always fascinating because it leads me to learn more. So anyway, this is what happened. I had a case of COVID-19 beginning first symptoms on December 28th. So that was the Saturday after Christmas. I used a nicotine patch and ivermectin and had a very easy course of it. 1 week later, I would not have known I had anything. So I did have symptoms like headache, and I definitely knew, because I've had COVID before, that it was COVID, but it was very, very mild. I didn't have any disruption to taste and smell. I didn't have, anyway, but I did get my nicotine patch on right away. My husband did have taste and smell disappear, but after 3 days on the nicotine patch, it came back completely, both. So that was really cool, but I did not really have symptoms like that. But I did know and also because I have not been sick except for having COVID twice now, in at least a cold in at least 30 years, probably longer. And it doesn't respond to like nip it in the bud and your typical things like that. So in any case, I am actually going to take a brief minute because my eyes feel dry. I'm going to stick an eye drop in each one. Just bear with me. So how appropriate do you need to use eye drops while you're about to talk about the eyes? It feels really good. Those are our MSM eye drops. Those are the ones with magnesium and sea buckthorn oil. Somebody wrote a review on the ones with all three on my website and said it was a half a day with the oil in the eye drops that she couldn't have clear vision. So she did something wrong. It just doesn't, I mean, I have perfectly clear vision. I just did that. Just make sure you shake them up good because the oil can tend to separate, right? So you're not getting just oil in one drop. That might have happened to her. I'm not sure. Okay. So, however, on January 8th, I noted the sudden appearance of a very pronounced floater in my left eye. I do not have a history of floaters. This was accompanied by flashes of light, like off to the side. I would notice when in a dark environment, like say I went out from the office and I'm going down out to my car to go home for the evening. I'm getting into my car. I would see these like flashes of light on my left side. Realizing this indicated retinal related problems because they tell you if you have a sudden appearance of floaters or you have flashes of light or whatever, get immediate attention because it can be something to do with your retina and you don't want to have a detached retina, et cetera, et cetera. So anyway, I made an appointment with my eye doctor who got me right in. She has always remarked that I have the eyes of a 20-year-old, and this time that held true. Your retinae are like those of a 20-year-old. Your arteries are perfectly clear. Everything is perfect, but what I had, you have a posterior vitreous detachment from the retina. So let's go down here to the eye, and you can see here the retina is this yellow part here, right here. It goes around your eye. It's in the back of the eye. This is the vitreous gel that attaches, that goes along inside it. It's supposed to be nice and snug right up to the retina. And so what happened when you have this vitreous detachment is that the liquid is like a gel consistency, and then it liquefies and now begins to pull away. And the floater material is the floater that I see is that vitreous material that pulled away and is now there where I can see it in my vision. So anyway, I was fascinated to learn that this means the thick gel that surrounds the retina had liquefied and pulled away. That is the material that flung out into the body of the eye and caused the floater. The flashing of light is the pulling of the vitreous on the retina. So as it has this pulling action, it doesn't mean every time you see a flash of light, you've pulled some more away, but it's the pulling of it. So she said, for the next 2 weeks, I'm going to see her again Thursday for a follow-up. And we'll take a look and see where things stand. But she said, don't be doing things like lifting heavy things, shoveling snow, doing something jarring, because we don't want to, shake it up. But anyway, that is what's going on with the flash of light. Anyway, this is something that can happen to people as they age, as the fluid becomes less thick. So it's one of those things that can happen to your eyes as you get older. I am 66, and I suppose that could be the explanation in my case, although my eye health history would tend to make that scenario less likely. Also, and this is something I've always done with all of my clients throughout the time I've been practicing, and that is to ask, when something sudden happens that's unusual, do you remember something being different? Were you sick? Did you get a vaccine? Did you have an accident? Was there even an emotional trauma, or what is it? Because when something happens, all of a sudden it appears, it rarely do those things happen in a vacuum. Okay, I'll give you a perfect example. So I have a client who was in yesterday, and she noted that her sleep generally in life, this was a follow-up, so we've worked together. Her sleep generally in life has been very good and steady. She would, wake up maybe once during the night, roll over, fall right back to sleep and get up, no problem. So based on something else, the last time she was here, we had noted, thought that maybe her iron was low. And she said, well, my iron has always been on the low side of normal. And during the summer, she had had some heavy bleeding with her period. So we started her on 25 milligrams of iron bisglycinate. So then she said to me, since that time, she hasn't had heavy bleeding. When she first started using the iron, that her sleep improved. Her sleep got really good. And then it didn't continue to hold. And now she's waking up like 10 to 15 times during the night. So I said, well, that's really weird that you noticed your sleep improve with iron supplementation, and then it didn't, but that it didn't hold, didn't make sense. But anyway, I didn't know of any connection between iron and sleep, but sure enough, sitting here, this is how my clients always, working with my clients is called practice, and this is how you find things out. There can be a very clear correlation. So we're still mystified, like, well, then why, when you started the iron, you noticed a difference? Well, as an aside, toward the very end of the visit, because we were like, well, we don't have any way to know like what your iron levels are, and you don't want to just make an appointment with a doctor just to get an iron level. She goes, oh, well, she said, I gave blood 2 weeks ago, and my iron was at 13, and they like it to be at 12. So that's, if it's at 12, if it's below 12, they won't let you give. And I'm like, wait a minute, you gave blood 2 weeks ago. How long have you been having trouble sleeping? She's like, yeah, for about 2 weeks. Okay. So sometimes you just have to say, right, because she already has iron on the low side and she donated blood. So she just got rid of iron. So we said, well, you know what, triple your dose here for a few weeks and get that iron level back up. Because I mean, honestly, the top range would be 26 and she's typically around 13. So going on so anyway, I give that illustration as always think what changed. And the only thing that really had changed for me was I had COVID. So anyway, this is really a good paper. So anyway, before I had my appointment, I had already investigated any possible association with COVID-19 and retinal problems. Oh, yes, I knew that when I went in. I even brought her a paper. Oh, I brought my doctor this and I said, are you aware of like these eye problems, like retina problems that can come with COVID? And she goes, oh, yes. She goes, you wouldn't believe the things we're seeing. She said, we had one woman who had 3 instances of one of her eye pupils was dilated, like beyond what it should be, and the other one was normal. And anyway, she said, after all of this happening several times, we finally correlated that this happened after she had COVID 3 times. So it is definitely something that the eye doctors are noticing. And she said it can be all over the place. So this is really a good word to get out there to you, because you might yourself have noticed something with your eyes, after having had COVID or after having had a COVID vaccine. You might know somebody, or it's just good for you to know, so that if you know somebody who later in the future, right, says to you, oh, I've had this, I've got this going on with my eyes or whatever. I don't know what's going on. It's just, did you have COVID? Maybe it has something to do with that. Anyway, I find it fascinating, but of course I would. So let me see, go up in this one. I have a lot of several papers on there. You can see talking about ocular issues related to COVID and vaccines. I can't see where I am because I've got okay, let's go up to the top. So vitreoretinal abnormalities in coronavirus disease, 2019 patients, 2019. And this was published in 2021. So I thought, findings show vitreoretinal involvement in COVID-19 patients, including the central retinal vein occlusion, central retinal artery occlusion, reactivation of previous uveitis, so inflammation of the uvea, chorioretinitis. So let's go back to our illustration here. The choroid is here, the retina is here. So they're very close to each other. Paracentral acute middle maculopathy, vitritis, so inflammation of the vitriol, with outer retinal abnormalities, varicella zoster virus related acute retinal necrosis in an immunocompromised patient, and another posterior segment pathological changes. So that would kind of be sort of like what I experienced. If you look at, this is like a posterior vitreous detachment. So in the back, right, posterior, and it's kind of pulling away from there. It's so fascinating. People don't like to get their eye pictures taken. I love it. Number one, it doesn't bother me, like staring at that bright light. It doesn't bother me at all. I love looking at the photos. That is just so amazing. And being able to see everything, see the optic nerve, see the macula, see what's going on. I was able to look at that floater, which he told me I will always have now. But I have to say it's really lessened in its the darkness of its borders. So we'll see where that goes. I just can't wait till Thursday till I can get pictures taken again, and we'll see what happens. But anyway, okay. So now, most of the things that are going on, like rather than just read you every paper, and I'm not going to do that, but I do want to hit some highlights. The biggest things we see are the things that are vascular in nature. And that makes all the sense in the world, because we already know that COVID-19 can cause a hypervascular hyperthrombosis, like the blood clotting, the blood getting thicker, the fibrin and things like that. So we already know that. We know that the shots do that. So we see possibility of stroke and blood clots and heart attack, what do I want to say? Heart attack and cardiac arrest, those kinds of things. And so we know and so what do we do in the natural world to help with those kinds of things? Is we use proteolytic enzymes, serrapeptase and nattokinase, bromelain, things like that. Those are the things I use typically, are serrapeptase and nattokinase, and I take those every day myself. Again, on examination of the photos of my eyes, my vascular health is, like she said, and she's always said, but still after this happening, like that of a 20-year-old. So very healthy eyes. And I was glad it was nothing of that like that. And it really shouldn't have been, because I always take serrapeptase and nattokinase. So I'll get a little bit more towards the end talking about how you can use those things to help protect yourself. And it's not a bad idea in this day and age where COVID is everywhere, and pretty much everybody's exposed to it in some way or another. So anyway, blah, blah, blah. It has been reported that COVID-19 can have several organ-specific involvements, lung manifestations, including diffuse pulmonary, intravascular coagulopathy. So you've got the pulmonary arteries and all of that having a problem with that. Silent hypoxia, acute respiratory distress syndrome, renal kidney involvements range from mild proteinuria to severe acute kidney injury. Again, thinking beyond, we tend to think of COVID as an upper respiratory, and that's where your most in your face symptoms do appear. And what you would think of, I had a bad cough, I had blah, 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 in fact, my eye doctor asked me, did you have like a really bad cough with COVID? Thinking that maybe like that was like just shaking my vitreous my vitreous gel off the retina. But I didn't. I coughed occasionally to you know, clear stuff, but I didn't have a cough. So anyway, hematological involvements. So blood, it consists of blood count abnormalities and coagulopathy. So again, the thickening of the coagulation of the blood, forming clots and that kind of thing. Skin manifestations include direct skin lesion and underlying vasculopathy. So some inflammation there of the vasculature in the skin. Neurological features comprise inflammation of the brain, cerebrovascular events like stroke, and encephalopathy, which is like inflammation of the brain. Finally, the cardiovascular involvements consist of Kawasaki-like syndrome, acute myocardial infarction, and decompensated heart failure. So there can be many things. I had a client, kind of an older man, kind of older Yankee, I would say, with, I don't mean any disrespect with that or anything, but he said to me the other day, he said, oh, isn't COVID just like a, kind of like a pneumonia that's been around forever? And I said, oh, absolutely not. COVID is not something that's been around forever. Coronaviruses have been around forever. COVID-19 was a gain of function research put to warp speed. Okay, so like Lyme disease as we know it today, they took the Borrelia bacteria and they engineered it to make it impossible to kill, to use as a bioweapon. So COVID-19 is like a bioweapon. It is something that has been engineered beyond its natural capacity. It's been souped up, right? Like a souped up engine or whatever. It's been made to be difficult to treat, difficult to be, basically, yes, it could be used as a bioweapon. And so that's what we have to understand about this. It's not like everything else. And some of us in the natural world and didn't want to make a big deal about, or, you know, not wanting to make a big deal about COVID and say it's different than anything else. It is different than other things. It's different because of that very reason. And it didn't start in Wuhan. It started in the United States at Chapel Hill, North Carolina, under Ralph Barrick years ago, when things got hot. And under the Obama time, Obama said gain of function research could not be done here. We shipped it over under the guise of EcoHealth Alliance to Wuhan. And perhaps they were working on it too, but let's not say, you know, I'm so sick of hearing this be called the China virus. This is the North Carolina virus. How's that? And that was very involved with Anthony Fauci. So, which is probably why he was given a preemptive pardon. Anyway, so COVID is different. Okay, let's see here. A number of studies have reported the ophthalmic signs associated with COVID-19 infection. A significant number of patients infected with COVID-19 experienced conjunctival congestion, chemosis, aphoria. Okay, so watery discharge. So basically conjunctivitis. Furthermore, new onset neuro-ophthalmic diseases in COVID-19 patients have also been documented in the literature recently, including Miller-Fisher syndrome, isolated cranial nerve palsies, ocular myasthenia gravis, neuromyelitis, blah, 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 blah. So you can see a lot of things there. Given the ability of SARS-CoV-2 to cause neuro-ophthalmic manifestations in anterior segment inflammation of the eye, the possibility of the virus to manifest into vitreoretinal disorders should also be considered. Limited number of studies describe the new onset vitreoretinal disorders in patients with COVID-19. This review article aims to gather the information regarding the vitreoretinal manifestations of COVID-19 patients that have been documented in the literature so far. To date, this is the first review article specifically evaluating this particular issue. And so we go through here. I'm not going to obviously go through the whole entire paper, but 2 papers with the absent, blah, 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 2 papers with, so they evaluated all the data they could get that was out there. So currently it is challenging to provide information regarding the presence of vitreoretinal abnormalities in COVID-19 patients. Limited reports regarding this topic have been published. As detailed, a total of 14 case reports, 2 cross-sectional studies, and 2 prospective cohorts were included. Consequently, COVID-19 has been associated with several vitreoretinal abnormalities, including central retinal vein occlusion, sentinel artery. Okay, we talked about that. Okay. Now, I think down here, so this is kind of interesting, like these are different papers, right? Okay, so acute vision loss of the right eye, acute vision loss of the left eye, bilateral macular hemorrhages were involved in there. Redness in both eyes, so vitritis, so that's inflammation, reflective of disruption of the outer retinal layer. So that would be like your vitreal layer, like mine was pulling away. Acute vision loss of both eyes. Oh, and let me just say, you have to be very, don't let this go. Don't go, oh, I had COVID, now I have a big floater and now I've got white flashes. No, go to your eye doctor immediately and get an exam and find out what's going on. And you're going to have to proceed with some caution to keep that from getting worse. And of course, my thing has been, if you have any sudden thing happen, like all of a sudden, like a curtain comes down or anything weird, anything different, come right back immediately. Because you don't want to be careless and find yourself with a retina. You don't want to go blind, right? Don't want to go blind. Floaters and reduced vision of the left eye, acute vision loss, negative scotoma and dyschromatopsis of the left eye, decreased contrast sensitivity of the left eye, multiple violet scotoma of the right eye. So scotoma is when you've got like a section, you've got clear vision around it, but in that one spot, it's something else is going on. Near vision difficulties, redness, burning sensation, and photophobia, like sensitivity to light. There was none in that one. Retroocular pain. Eye pain and near vision difficulty, blah, blah, blah. Reduced vision of the left eye, temporal relative scotoma of the left eye, reduced vision of the left eye, paracentral scotoma of the left eye, acute vision loss of the right eye. I thought this one was really interesting because I found SARS-CoV-2 infection was proposed to have played a role in initiating choroidal inflammation. A case record by described a 40-year-old, 1-year-old woman with blurred vision in the left eye 1 month following a mild COVID-19 infection. At the time of examination, the patient was already considered cured for COVID-19 as she was tested negative for PCR tests 2 weeks following the COVID-19 diagnosis. On examine, the visual acuity of the left eye was counting fingers at 2 millimeters, I guess. The left eye fundus examination was consistent with her older lesions showing multiple blah, 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 alongside blah, 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 blah. Or they were already present. Okay, so she had other stuff going on in her eyes. Okay, but this particular one was, this suggested the possibility of serpiginous choroiditis reactivation in the patient, which was mediated by the SARS-CoV-2 infection. The lesion was shown to be responsive to high-dose corticosteroid. This one is another case demonstrated the case of a 51-year-old woman with ocular pain and reading difficulty. Fundoscopic ultra-wide fundus, outer retinal layers. These findings were consistent with the presentation of inflammatory chorioretinal disease. So again, we go back to our diagram, got the choroid is right there, the retina is right in front of it. So involving this area. Especially acute posterior multifocal placoid pigment, blah, 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 blah. Patient was tested negative for other things that might cause that. Anyway, then they know that she had COVID. Okay, anyway, this is very interesting. What was the one that I saw? decreased visual acuity in his left eye, negative glaucoma, blah, 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 blah. Oh, this one, because mine happened exactly 12 days following the day my first symptoms appeared. So vitritis, an inflammation of the vitreous humor, has been observed in a newly diagnosed COVID-19 patient. So-and-so reported a unique case of a patient with intraocular inflammation, vitritis, and outer retinal layer abnormalities 12 days following COVID-19 symptoms onset. So I went and I counted between December 28th and January 8th when this first appeared. And it was exactly 12 days. So anyway, within that whole time frame of what might happen, just telling you, because if this happens to you, don't don't be neglectful of paying attention to it. I did actually not call my doctor until Monday, which was the 13th. I should have done it sooner. But anyway, all was well, but don't wait that long. Because you really do want to know what's going on so that further damage does not occur if it can be prevented. Other posterior segment pathological changes. And yeah, they're just kind of running down through all of those things. So I guess what I want to say with regard to this topic is to be aware that, oh, let me just also show you, got a few other papers on here. Oh gosh, there was one that was like, okay, this one. So let's take a look at that. COVID-19 and vaccinated associated ocular complications. COVID, blah, 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 blah. Increasing evidence has raised concerns about the associated ocular disorders in patients with SARS-CoV-2 infection or COVID-19 vaccination. The virus can affect the eyes directly or indirectly. The reported ocular manifestations due to COVID-19 vary greatly, include dry eye, conjunctivitis, scleritis, uveitis, endophthalmitis, retinopathy, and retinal vascular occlusions, acute glaucoma. Like all of a sudden you have glaucoma. You never had glaucoma before. Optic neuropathy and cranial nerve palsies. In a questionnaire survey study reported that the degree of ocular inflammatory activity within 3 months before is a major recurrence risk factor. If you had an ocular inflammatory activity before you get it, you have a major recurrence risk factor. So that's something to know too, right? So suppose you've already had something, some sort of optic inflammation, some sort of syndrome or something within 3 months, and now you get COVID. Or one might actually extrapolate and say, and now you get the COVID shot. So another thing to be, on that warning package, before you get the COVID shot, before a person gets the COVID shot. I know. Anyway, okay. Retinopathy, acute glaucoma reported, blah, 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 blah. To investigate if ocular tissue and potential infectivity of lacrimal fluid ocular infection of SARS-CoV-2 found that SARS-CoV-2 could be detected in the eyes of some of the infected patients, albeit at lower levels compared to the nose. They also found that the lacrimal fluid can be infectious with high viral load in these patients. The impact of SARS-CoV-2 on periocular injection pain and hypersensitive reactions is a specific and somewhat niche area of interest within the broader scope of COVID-19 related research. While comprehensive studies addressing this topic might be limited, we can infer potential impacts based on the known effects of COVID-19 on the body's immune response and the potential for increased sensitivity or inflammatory reactions. In an interesting study, Liu et al. Investigated various indicators in patients who had received Botox injections at the same site before and after their infection, including pain scores, allergic reactions, the occurrence of complications, suggesting administering toxin type 3 weeks after COVID-19 recovery is a justifiable and safe approach. I haven't looked into that. That's very interesting. While COVID-19 vaccines are generally safe and effective in preventing severe illness, well, we would many times disagree, but this is their standpoint. There have been rare reports of ocular disorders following vaccinations, such as uveitis, adenoviral conjunctivitis, retinal vascular occlusions, optic neuritis, and possibly corneal transplant rejection. Okay, so so-and-so et al. Reported cases of ocular complications after vaccination, including the Pfizer-BioNTech vaccine and Oxford AstraZeneca in 3 different eye centers in Malaysia. They reported 4 cases with acute retinal pigment epithelitis within 3 hours of vaccination, unilateral choroidal neurovascularization 3 days after vaccination, bilateral acute multifocal placoid pigment epitheliopathy a week after vaccination, as well as herpes zoster infection and unilateral anterior non-granulomatous uveitis 2 weeks after vaccination. The possible mechanism remains unclear. They postulated that a possibility of the vaccine-mediated immune response leads to an increase in the inflammatory mediators. Anyway, so we do see this connection. The next connection is, again, not something that probably a lot of people know about, but there's plenty, you can see there's plenty of literature to support that. So then I say here, as you can see from the above, most of the ocular problems involve thickening of the blood, thrombosis, if you will. And this is the key problem with COVID-19 and the vaccinations to vascular problems such as stroke and heart attack. That wasn't my problem, but my problem was more like that, probably that immune response or whatever, causing some inflammation. If that's what my problem was, it could have been purely coincidental and this was just going to happen. But anyway, I just don't know. I doubt it. So anyway, I typically, however, the approach I would take for vascular problems affecting the eyes would be the same as the approach for COVID-related vascular problems anywhere in the body, proteolytic enzymes. I typically use serrapeptase and nattokinase. Bromelain is another, but the former are my favorites. They're the ones I've used. Again, you got to take your bromelain. Sometimes people are taking bromelain, and it says on the bottle to take with meals or in between meals. So if you take a proteolytic enzyme with a meal, it just digests your protein in your food. It does not do anything that you want it to do. Like people take bromelain for their arthritic inflammation and things like that. You've got to take that between meals if you want it to do anything in that regard. Same thing with serrapeptase and nattokinase. Both are, serrapeptase is a proteolytic, and bromelain comes from the tops of pineapple. Nattokinase is from a fermented soy. Serrapeptase comes from silkworm. And so they all have these proteolytic enzyme things. So they go after, what do proteolytic enzymes do? They go about digesting protein that shouldn't be there. So excess fibrin in the blood, scar tissue in your body, adhesions, excess mucus, things like that. So, so I use nattokinase and serrapeptase with a lot of people. I use it myself. We have cardiovascular disease in my father's side of the family. Just want to make sure, you know, I keep my arteries and my veins as healthy as possible. Also for the other reasons. But in this day and age of so much COVID being around and everybody being exposed to it, a lot of people have had it. And then also everybody, a large part of the population being vaccinated, it's not a bad idea to keep that hyperthrombosis, that hyper replication, or if you will, of the blood, making it thick and causing clots and things like that. So I will only tell you this. I've used serrapeptase with a lot of people, and I've seen really miraculous things in some cases with it. I've had 2 women in all that time who had a very bad reaction to it. So they both ended up with extreme, like, projectile vomiting. So I have to tell people about that now, just as a precaution. It's not something that, again, you see very often, but my client, the second one had happened to, and this happened years apart. One was years ago and one was more recently. And she went online and found people talking about that. If you have a reaction to serrapeptase, it's gastrointestinal, it's this kind of thing. And it's pretty nasty. So I will tell you that. But I do like serrapeptase is probably my favorite. And again, for 99% of the people, it works really well. I guess I would say, if you wanted to know, you could always take a little powder out of the capsule and just take a little bit. But again, it's kind of like Russian roulette that way, right? It's kind of like there's going to be 1 in 100 this might happen to, but you don't know if you're the one. So I only apologize if I recommend it to you and that happens to you. Again, the hypercoagulation state that happens with this. So I guess that's all I really want to say about that. Again, you can see a lot more information on my my page, and always will be getting more and more things up as I find them and adding to my files. But again, it's a good database for you if you're like want a place to kind of hone in. Somebody's gathered, like me, I've gathered material together and put it in one place. Not that you're not going to look elsewhere, but it's a good place to start. A lot of good stuff there. And I don't have it really organized well between different topics. I'm trying to do that more as I move forward with my pages, as you can see, like with these sections. Make them a little bit more, calling your attention to whatever I'm talking about. So anyway, I've got a few more minutes left. So what I'm going to do is stop my share, and I'm going to share this with you since we're talking, there's a show and tell, things that happened to Becky. I'm going to tell you this rather humorous story now that it's over, but it wasn't very funny when it happened. And this is related to something that happened to me back like 2 weeks before Thanksgiving. So I have to preface it with the long story. So years ago, Dale is an engineer, and in his work, he did a lot of travel across the world for many years. And one time about, I don't know, 30 years ago, I traveled with him more than once and went to some really awesome places, but we went to Belgium. And this was about 30 years ago. And we were at a restaurant, and they use a lot of dried thyme in the Belgian cooking. And there was this dish I got, a chicken dish, and it was delicious, but it was loaded with thyme. And in one of the bites I took, I got a stick of thyme, actually. So the Wharton's duct is a salivary gland, like right below your front lower teeth. And it's like the major outlet. There are other areas, but it's like the major outlet for your saliva when you're eating. And so anyway, I got it stuck right in there, and it hurt. And then it also caused like a backup of the flow of saliva. So when I got back to the States, I went to see an ENT doctor who I knew because he was a client of mine when I was doing medical transcription. So when my daughter was a child, when she was at home, when she was a child, I started a medical transcription business out of my house so that I could work at home. And so I had different clients, and I would type their dictation, which actually ended up to be really great for what I do now, because I got to be a fly on the wall in a bazillion doctors' visits and know what goes on and what they do and how they work and what they prescribe and all of that. But anyway, anyway, I got in touch with him and just met him outside of office hours, and he was like, yep, there it is. And he pulled out and it was bleached by the time that happened. It actually bleached, but it was a stick of thyme. So in any case, that ended up causing a scar tissue to be in that area. So every few years, I'll get like a backup of, my saliva doesn't want to flow. And you can kind of, it'll kind of get, so you can see like a little, not like I have full blown mumps, but a bunch there, and I'll just kind of massage it over a couple of days. It'll clear out. But this time it happened on the Thursday before 2 weeks before Thanksgiving. It happened, and it didn't clear, and it got worse. And by Sunday of that week, I brought home like a little pump for a lotion, like one of our lotion pumps, and I stuck it on there, and I tried to, it hurt like heck. This is super painful. And I tried to like put some suction on it to see if I could just pull it free. And nothing happened. And the pain got worse because the saliva was backing up. It was like this, my tongue, I couldn't even lick my lips because I was so swollen underneath here. I could not eat. I came to work by Sunday, Monday, Tuesday, Wednesday. I came to work, but I was on Advil around the clock and had difficulty talking with my clients because it sounded like this, but it distracted me when I did that. So I really didn't, it was better if I was working. So also another really funny thing that happened during that time was that I couldn't eat. Number one, you can't eat because if you eat something that tastes good, you salivate, you just make more saliva that has no place to go. It's dreadful. And then you get to the point where you can't swallow very well. I had to take all my supplements one at a time. And with all the supplements I take, you can just imagine, it took me like 10 minutes. So I tried to do like a little bit of like a protein shake, but I couldn't get that much. Anyway, so I was basically fasting, drinking plenty of fluids, but fasting for that Monday, Tuesday, Wednesday of the following week. And this is what happened to me. Now, I find that in my relationship with God, that when I'm going through something that's hard, I will feel his grace and I will feel like a good feeling in spite of it. It's almost like he says, my grace is sufficient for you. So I've noticed when times have been difficult, I get more of that. And it's kind of like spiritual endorphin. So you feel happy in spite of the fact that you're worried about what the heck is going on with your mouth and you're in a lot of pain. And you don't know where this is going. But it went beyond that. It was like I actually almost felt euphoric. So I looked at that and I looked into the effect of fasting, possible impact of fasting on euphoria. And I found that when you're in the beginning phases of fast, you can actually affect certain things in the brain as strongly as the drug ecstasy that people take to feel euphoric. And all I can say is it was a really nice comrade to have during that painful time because I was just so grateful for everything. I just felt so thankful that, wow, this hurt, but my eyes work, my ears work, my legs, I'm so happy and grateful for everything. And it was really funny. So that's another thing I want to do. I want to explore fasting and the effects of fasting on the body and the brain and everything. So that'll be another webinar sometime. But anyway, to continue with this story. So Wednesday night, I go home and I'm on Advil every 4 hours around the clock. I'm on PEA Pro. I'm on everything. And this is like, I have to just take the edge off. So I'm praying and praying and praying. I'm on the couch. I'm on my couch. Dale's on his couch. We're watching the TV and I'm just praying like, what do I do about this? Like, what do I do about this? So I go into the, most people would say, go to the emergency room, but I just knew that was probably not going to lead to great expertise about the salivary duct. And I just didn't. So, and my favorite oral maxillofacial surgeon here in Keene, Len Weldon, had retired. Little did I know that he's actually working at Keene Dental to do some work for them now. And if I had known, I would have certainly gone to him. And I ran into him 3 days after this happened and I told him the whole story. But anyway, I would have done that, but I didn't. So anyway, that's what I did. So I go into the bathroom praying all the time. What do I do, Lord? What do I do? I don't want to look at it, but I have to. So you have to understand, I lift my tongue and this is all swollen under my tongue. And it's like pressing against my teeth practically. And I lift and I look with a flashlight and I can see what looks like a little something white, like a white lesion, right? So I had bought and never used, I thought it would be handy to have just to have on hand for whenever, a whole set of dental hygienist tools. So I go and I get like a little hooky thing, and I'm sure there's a name for that. And I kind of rub that white thing and it scrapes like stone. So I go and I get the little forcepsy thing, like a long handle and a little like tweezer, but like crooked, like at a 90-degree angle. And I grab it, and you will not believe what I pulled out of my salivary gland, out of my Wharton's duct. This is my show and tell. Oh, I don't want to lose it. Okay, can you see that? I put it up against something dark. Hang on. Oh, I can't coordinate this. Do you see that? That is 15 millimeters. That came out of my salivary gland. This is what we call a sialolith. It is a salivary stone. And this is considered a giant stone. I sent Len Weldon a picture of this. I emailed it to him. And then I saw him 2 days later at the co-op again. And he was like, wow, this is considered a giant stone. So most stones are like 2 millimeters to 10, like sort of max. This is 15, and it's wide, as you can see. So no wonder it was causing me a lot of pain and causing a backup. So I never knew that there were stones involved in my case. I just thought it was scar tissue. Plus, anyway, I won't go into that part of the story because it'll just take too much time. But I do, okay, so, but I do a lot of dairy, right? Yogurt, I put up until now, I don't do this anymore. Milk, whatever, half and half in my coffee or whatever. So these stones are made of calcium, and they're mostly calcium something and calcium hydroxyapatite. And I also was using Lurong. I've been taking Lurong for several months or maybe a year. Lurong is deer antler velvet, and it's really good for most people. But it's a rich source of calcium hydroxyapatite. So these are calcium stones. So like a kidney stone, like calcium is involved in kidney stones. So what I do is I have a kidney stone formula for people who get kidney stones or who get a kidney stone, and it has gravel root. Gravel root is a really cool herb that breaks up stone. And so I have it here. It's one of the things that I take on a regular basis, on a daily basis now, is gravel root. And I'll like swish it around over my salivary ducts and drink it to make sure I take it internally. I also am taking magnesium and potassium citrate, because magnesium and potassium citrate are what we use to stop stones from forming. And I limit my dairy. I don't avoid it completely. You know, I might have cheese on something. It's that I just don't want to be bathing my salivary ducts with dairy, is where I'm coming from. But that's a fascinating story, right? Are you fascinated? You have to be. And that is just really wild. Most people who get salivary stones, it's usually men, or it's people who are alcoholics or smokers. I'm neither. I don't even drink alcohol. But people who have had trauma to the salivary glands, and sometimes when it's very severe, you actually have to have the gland removed, and then that's a big, to do, because you've got nerves involved, and it can really affect your taste buds and your ability to eat well and everything. So I don't want that to happen. So I had thought I might take this sucker and break it in half. Thank God it didn't break when I was trying to get it out, right? If there was some, but I thought I might break it in half and put one half in a solution with gravel root in some water, and the other half in some put some potassium magnesium citrate in the other half, and see how well they work at dissolving it. But then I would lose my trophy. So I don't know. I'm really torn. I kind of like, I just kind of like looking at this. But you should have seen my husband when I come out with look what I just pulled out of my mouth. I was like, what? So anyway, that's my story. It's 1 o'clock. Thank you for being with me. And I'll be back next week. Not sure what I'm talking about. Maybe I'll talk about the effects of fasting. Maybe fasting on a broader in a broader way, but also to include that, that saving grace that I experienced, for 3 days, where I just felt so happy that while I was so miserable. But anyway, I hope you have a great weekend and a wonderful week ahead. What do I put in my coffee now? I put maple syrup, vanilla extract, 2 drops of peppermint, 2 drops of peppermint extract, and a good several shakes of cinnamon. That's how I like it. And it's really creamy, like you would never know. Would never know it doesn't have cream in it because it has a real nice body to it. So that's my kick right now. I mean, I like coffee black anyway, but over the holidays, I really got into the whole peppermint taste. So I really love vanilla, cinnamon, 2 drops of peppermint extract, and a dollop of maple syrup, real maple syrup. That's what I've been doing. I love it. I'm going to have a cup as soon as we're done. Okay, so goodbye, everybody. Be well. And again, we'll be back together next week. Thanks for being here.